Well, welcome. We're going to move ahead to the next session. Congratulations to the winners in the last session. Welcome. My name is Dr. Donald Lloyd Jones. I am a longtime AHA volunteer, past president of the organization. I'm a cardiologist and cardiovascular epidemiologist. And I'm so pleased to welcome you to our session today entitled The Power of Community Health, Where Health Begins, where we're going to explore a number of different ways that we can engage patients in their communities and obviously, hopefully improve community health by doing so, leveraging innovation and technology. So that's why we're here in the Health Innovation Pavilion. Thank you all for joining us today. I'm so pleased to be joined by a very distinguished panel of discussants who are going to share with us some of their expertise in engaging community organizations and community individuals in attempts to improve health. And they're going to start off with about a 5-minute discussion of the kinds of things that they leverage to improve community health. And then we're going to have a nice round-robin discussion. So hopefully that'll be entertaining for all of you. Immediately to my left, Dr. Tiffany Powell-Wiley, who is a longtime AHA volunteer, and she is a leader in integrating digital health technologies into community-based interventions, particularly when those affect underrepresented and underserved communities. So Dr. Powell-Wiley, thank you so much for joining us. Dr. Scott Conard is the co-founder of Converging Health, and he works at the intersection of clinical care, healthcare organizations, and healthcare organization leadership and value-based models, and has a particular interest in proactive health strategies that can include moving care closer to individuals in the community. Scott, welcome. Thanks for being here. Dr. Courtney Scrubs is a medical doctor, but also chose to practice law with that degree. So a dual threat, clearly. She was a leader in the Student National Medical Association, and currently the co-founder of the Strategic Wellness Initiative, which is advancing health equity through education, collaboration, and community engagement. And last but not least, at the end, my friend and colleague, Dr. Eduardo Sanchez, who is the Chief Medical Officer for Prevention for the American Heart Association, but has a long and checkered past prior to that as a leader of both insuring organizations, but also state public health commissions, and has been a practicing clinician. So lots of great experience on the panel. Tiffany, maybe I'll turn to you first to talk about your experience with, again, integrating digital health technologies to improve community health.
Sure. Thanks so much, Don, for the introduction, and thank you all for being here. So, our work and my work around working with communities and working with digital tools and digital health really started by building relationships with community members in the Washington, D.C. area. And it really was about understanding what we could do to improve cardiovascular health in the community. And we didn't necessarily go in saying, this is a type of intervention that we wanted to do, this is the type of digital tool that we wanted to utilize. It really started with just building trust through work with the Community Advisory Board, called the DC Cardiovascular Health and Obesity Collaborative, really working from the ground up to determine what types of interventions might be possible within the community, working with community members to better understand how they were already using digital tools, things like wearable devices, but also digital apps. What were some of the barriers for utilizing those tools? For instance, at that time, when we really started the work in 2012, even issues around broadband access and Wi-Fi access were fundamental. And so that work has really grown to now implement not only interventions, but also work directly with the community and understand exactly what our future interventions might look like. And those may include artificial intelligence, those may focus more on nutrition and food security. And so we're really now working within an alliance, a research alliance with the community to better understand where we're going to go.
Outstanding. So truly meeting people where they are, but also understanding what tools they need to be able to engage you using digital health technology. And, I think when I'm in rooms where it's being discussed, how we're going to engage with particular communities, and we talk about the availability, not just of broadband, but of cell phone access. And how much is that a limitation these days? The counter is always, well, everybody has a cell phone. But is that really true? And are there concerns about that?
So in terms of cell phone access, it is relatively true that most people have access, particularly within the U.S., but access to the data plans that allow for utilization of all types of digital tools, that still can be an issue. And so we've dealt with some of that within our interventions, making sure that we're able to provide resources if we can for those who may not have the digital plans that allow for different new apps on their phones. And we need to think of that as we build apps that are even more complex, particularly as we bring in machine learning and those types of things.
Really important, and we're going to come back to more things. So, Scott, maybe I'll turn to you and give us some of your perspectives on improving community health.
Yeah, so thank you very much. You know, I really would say that illness occurs one person at a time, but health occurs one community at a time. And the point there is that we've got to shift our focus from being an illness treatment system to a health and well-being promotion system. And to do that, we've got to start to think differently. And while I love the AHA and all these fancy drugs and all these fancy procedures, to me, this is hopefully going to be an antiquated, no longer needed at some point in the future, kind of approach to what we're doing. I think
Amen, brother.
Hello. All right. So, and the Life's Healthy 8, am I saying that correctly? Or
Essential
8. Thank you. So we need to be focused on Life's Essential 8 and how we get that to take place in communities for every person. So my life is using advanced analytics, working with brilliant people like Pat Dunn to figure out who within an employer population is actually at risk, because what we know is that they have no idea that they're at risk. And they're walking around waiting for the shoe to fall and to have something horrible happen to them. And so what we do at Converging Health, which is the company that I'm a co-founder of, is we get the claims information, we analyze the people inside of that population, we identify the 30% that are going to become high-cost claimants in the next 12 to 24 months if we don't get with them and help them embrace Life's Essential 8, as well as get a primary care clinician and get proactive. We know that 70% of those people, if they engage now before they have their event, will not have their event. 70%. So instead of stupidly wasting money on the fanciest drug and procedure after the event occurs, our life is trying to keep that event from occurring. And so that's what Converging Health does. We have an interface with the individual that is a human being, because we believe that the actual the currency is trust, and the interface is a human being to human being relationship. Now, we use all sorts of AI to identify what's the language that person's using. Are they have an internal or external locus of control? What's their health literacy? And are they competent to even lean in and embrace what they're going to do? And we work at the community called the corporation level. I'm also part of Primary Care for All Americans, which is committed to bringing primary care to every person in America and putting primary care in communities and available to every person in every community, which again harkens, and the kind of the battle cry is that health occurs and well-being occurs one community at a time, illness one person at a time. And let's try to get the community so that it supports people not needing treatments and interventions. And that's where I think we're in an inflection point when technology is turbocharging that right now and is going to make that possible. And corporations are willing to pay for it. And so we need to lean in to the community called Corporation Self-Insured and have them start to embrace that and change the outcomes for their employees.
Really wonderful discussion. Thank you. And I think you make the point that we use the word community, and that can mean many different things. And thinking about corporate partners in this realm, I think is incredibly important. Of course, in this country, that is the source of healthcare coverage. Corporations will tell you that their leading cost is the health of their employees, and yet, fair enough, and yet, they are doing often so many things that challenge the health of their employees. And so, how can we engage more effectively with corporations? You talked a little bit about this, but it's in their own best interest, and yet there are practices and other things that challenge the health of their own employees. So in addition to predictive analytics, what other sort of things can create a healthier environment within
Oh
the
my gosh.
corporation workspace?
Well, so first of all, you have to change the mindset of the CFO, CEO, and the president. And my favorite comment to them is the best way to manage high-cost claimants is to not have high-cost claimants, right? That's number one. And so getting them to think differently about that, getting them to switch from an actuarial approach, which is what they use right now, which is great 20th century technology, to a 21st century technology, which is clinical risk and clinical risk management, which has how much exercise do people get? How are they dealing with stress? It's your Life Essential 8. You are the author of that, so here I am talking to the man who actually did all of that. But if you take your Essential 8 and you look at how does the corporate environment support or not support that, that's where the conversation needs to go. But the second comment that I make is if your healthcare costs are going up, you're incompetent and you're not leaning in to caring for your employees. Right now, one of the things that we have found is if you identify at-risk people, you get them the services they need, particularly primary care and prevention, then you will have a flat or negative trend. And we have companies that have had that 7 years in a row. They are now 36% less expensive than their sister companies that have not been proactive. So if you're frustrated with healthcare, the second highest expense after payroll, and you want to do something differently, look in the mirror and get proactive, get preventive, and start to build a culture of health and well-being.
Outstanding. Couple comments. One, very much team effort and AHA supported on Life Essential 8. And two, you're naked, so I'm going to give you an 8 so you can wear it. There you go. Courtney, tell us about the Strategic Wellness Initiative and the kinds of work that you're doing.
Sure. So the Strategic Wellness Initiative was an initiative that was born out of a need to support an effort to make an impact in my community, basically. The short story is, as you see on the screen, my title here today is the Woman of Impact for AHA here in Greater New Orleans. Fundraising and impact competition. And as a part of that process, I was able to see gaps in where AHA was really trying to make an impact. ASHE, a local cultural arts center, a safe haven for a lot of people in our community, and also wanting to make an impact. And I saw a gap that I could fill and said, okay, let me, instead of fundraising and saying, okay, yay, I got the title, here's the money, saying, let's see, how can I leverage this opportunity to make an even greater impact with the other things I have to offer, right? So SWI is all about taking folks like me and mobilizing the capacity they have to achieve a common goal, right? The regular community member who may not be in a position of as a healthcare professional or a public health professional, but still has very unique and high value resource to contribute to impact in their community because they know their community, right? They have trust and they are culture bearers in their community. And so often some of the interventions that we so brilliantly developed, sometimes their impact is lessened because they don't translate to the people who actually may need them. And I think what we found, or what I've seen, is that sometimes you need folks to step in and bridge the relationship gap. And so SWI, very new, right now is working with ASHE to take the resources that we were able to raise under the Women of Impact campaign, put in place in this very critical safe haven institution in New Orleans, things like an AED machine, like the blood pressure kiosk, putting them in places where people aren't usually seeing them, right? So you usually see them in clinics, you see them in hospitals and the like, but putting them in a place like an arts center, because this is a place that people go and they're open and they're vulnerable and they're trusting, and this is the place where messages around health can really be received, right? And not maybe met with so much defensiveness or shutting down, because, to be honest, to be frank, sometimes when people in my community go to clinics, it's a scary place, right? And folks can shut down, to be defensive. And so what SWI seeks to do is to observe a situation, identify gaps, mobilize community resources, mobilize community capacity, and utilize the resilience and the capacity in that community to fill the gaps.
That's really wonderful, and I love the idea of putting these machines to help people identify or screen for health problems in places where they feel more comfortable.
Yes,
right.
absolutely.
Their blood pressure will automatically be lower. But talk about what happens next. So if you identify someone who has a health problem that was unanticipated, what's the connection then to empowering them and also connecting them to healthcare? Right.
So SWI can't take credit for that. We're coming in to fill the gap with taking folks who are maybe in ASHE for a different reason, right? For a wedding or a baby shower, and saying, hey, by the way, maybe you might want to think about walking on over to the blood pressure kiosk over there and getting your blood pressure taken. And so when some abnormality is discovered, ASHE has built out a wellness hub. And so it is a very accessible, low to no cost place where folks can come in and be screened, not just for cardiac issues, but other types of issues, and then be connected to healthcare providers who can help them to get care if they don't have it, or further coordinate care with their existing care providers. So it really, truly is an accessibility gap filler, 100%.
Wonderful, thank you so much. Eduardo, last but not least, you have such a broad range of experience and have touched so many of the community-based programs at AHA. Tell us about what you're thinking.
Well, I'm going to reflect and talk about some of the observations that we collectively made through a 4-year program called the National Hypertension Control Initiative, in which we were trying to, on the one hand, improve blood pressure control in 350 federally qualified health centers. These 350 were among the 1,500 that were the lowest performing. And then think about blood pressure control not only through what happens in the clinical care setting, but by connecting to community and community resources. And while it's really hard to work in 350 federally qualified health centers, there's a degree of capability and competency that exists there, not to judge, just to sort of acknowledge, that we found to be quite variable in communities. And so what we experienced was that there was, to frame this as positively as possible, an opportunity to enhance capacity and competency around a whole host of digital and information technology issues. Among them was the digital divide and digital literacy divide that is the reality in those who live in communities. Yes, they may have cell phones, and they may be very good at using the cell phones for a variety of things, but using their cell phones or their home blood pressure devices to check their blood pressure and have that connected to EHRs, I'll come to that in a minute, was something we recognized there was some variability in literacy. The second was really quite striking, was the variability in the ability of community-based organizations to realize the full potential of using technology to connect their clients, for example, to clinical care. Part of what we tried to do in NHCI was use social platforms, think Find Help or Unite Us, and to have those platforms, IT platforms, be a way where information about patient A from the social services agency might be used by the clinical health center, the community health center, to take care of the clinical care issue, and in turn, at the community health center level, see a patient who might benefit from 1 or 2 referrals to social services agencies and use technology to enhance those. There was a digital divide / deficit to be addressed. I say that because I think the potential is great, but we've got to pay attention to, just like anything, what's the readiness of a person and or an organization to fully engage in that technology solution. And as we do this work, we need to make those assessments and understand that it will take an investment of time, knowledge, competency to be able to fully leverage that. I want to hearken one thing Dr. Powell-Wiley mentioned. Very important that not Dr. Eduardo Sanchez or Dr. Tiffany Powell-Wiley say, this is what you need. It's really about engaging in that community conversation where the internal assessment is not being forced upon, but it's being asked for and then build from there. So I'll stop there.
Eduardo, it's a perfect place to stop because it really leads into what I wanted to ask all of you, because I think each of you in your own way touched on these principles of, I'll call it community-based participatory research. That's an old term. We now use probably more elegant terms for it, but listening first, last, and always, building trust, providing feedback, giving back to the community, and investing resources in that community, and not just taking from. But also, I think this idea that you really talked about there, which is eliciting from them what their needs are, and hopefully piggybacking that onto what we see we can provide in terms of promoting health as well. So
I'll just go a step further. Co-designing the solution.
Yes, exactly. So I'd love each of you to kind of dig in on this concept of how we do that. One, and it's good old-fashioned shoe leather. I know it's those conversations, but how can technology help us do it even better? So, open question. And while we're talking about that question, I'd encourage members of the audience to please come to the microphone and ask your questions as well. So please be ready for that. But let me open it to our panel to discuss some of the issues we just brought up.
Hey, listen, I will say I'm reminded by someone who's in the audience. It's not all doom and gloom with technology. So one thing that people do every single day is they text one another. And so clinic-driven text nudges and messages could be a way to get a little bit further than where we are now in terms of providing people with those nudges and messages, but also to continue building the capacity, the competencies, reduce that digital divide and that digital health literacy divide on the way. And by the way, if they're using their texts, if they're using text and responding to it, that is a way to hook people in and begin to say, well, what else might you be interested in doing with the very technology you have in your hand?
And I think the idea that it's not always that most high-tech solution that's required, but it's also, as you mentioned, really building out what the community needs, working with the community. So for us, it was fundamental that as we built out digital tools, as we built out mobile apps to work within the populations we work with in Washington, D.C., each piece of the digital app was piloted in the community. So they told us what are the parts that they liked, what did they not like. And now we're getting feedback on participants wondering, so where is AI in this? When are we going to get more automated messaging based on just much more tailored to what we need? But it really is about working and trying to get feedback iteratively throughout the process, and not just saying that this is a stagnant tool, but this is something that can grow as technology changes, but also as the community's needs change.
Other thoughts?
So I'd like to come back to a statement each of you made. First of all, I hope the American Heart Association is going to take your learnings from those centers and put them into a primary care package where every primary care practice can do a checklist to see how they're doing on that digital divide, how they're doing on utilizing community resources, how they're doing on making sure that they bring the proper tools to that. Because as a primary care doctor who runs a clinic, I would love that checklist because I don't think I am as competent as I'd like to think I might be.
So yes, and same thing, playbook checklist for community-based organizations. And honestly, this conversation has me thinking about, there's a couple of things that are missing on that playbook for the community-based organizations that should be built into it. So thanks for the comment. Yes and yes.
Well, AHA does it better than anybody. And coming back to something you said is you've got to meet the person where they are with what they need. And actually, I don't think that's a doctor 99.9% of the time. And what we find is that people who are like, believe it or not, the medical assistant, they understand the language of healthcare, they understand the process of care. So you get an MA who's worked in primary care for a while, and you put AI and other tools underneath that person and have them understand the community resources and things, and then have them reach out and say to that person, what's your concern? What's important to you? So why would you do that? Like, what is your why? And really anchoring it in understanding the purpose that they're going to be willing to do these different things is so much more effective than having a doctor tell somebody what to do. And it's really asking them into the conversation, meeting them where they are, and then guiding them to the next baby step of what they need to do. So it really feels, and technology informs all of that. Technology, Pat Dunn has developed a system, I don't know where he is, he's over here, called Signatures, where we'll take data and look at it, we'll ask the person questions, we'll see how they're thinking, what their mindset is, and then there are 5 different signatures that MA type person will start to communicate with that person through in a way they can hear the person who's supporting them. And so that's a perfect example of meeting people where they are with a very deep and sophisticated way of communicating effectively.
I love that. Courtney, thoughts here? And
Yeah, I mean,
we'll get to Dr. Shaw.
I agree with Dr. Scott so well, and as you were describing this way of working with the MA, it made me think about the Wellness Hub, right? And the folks who are working in the Wellness Hub are not medical doctors, they're community health workers, but because of the technology that AHA has put in the Wellness Hub with SWI, those community health workers can deliver real data and real results to that patient in a space that typically they wouldn't even have this kind of conversation. And so I think the future is leveraging technology to be able to provide even more sophisticated information. And so people can get what they need in a place that they want to receive it, and they are more receptive to it. So perfect example.
And Tiffany, I'm going to add to that. Providing community health workers with something as simple as an iPad that allows them to go into a person's, where they're invited to go into a person's home, and they can do an assessment as an example of what's in the refrigerator, allows for a much more informed conversation around healthy eating, access to not healthy food, the affordability of the affordability of the food there, and again, done in a way, not in an intrusive way, in a way that is about how one might go about having a conversation about what are the data points that the health system or the system could use to help you achieve whatever that goal is. So if you walked in and they said, we're just challenged with healthy eating, one way to address that might be, we can talk about it, but let's take a picture of what's in the refrigerator, or you tell us what's in it. I can imagine. Listen, I'll just be honest. I would never let anybody take a picture of my refrigerator.
I think I'm going to shut that down right there, Eduardo. We don't want to know either.
Yeah.
But you see what I mean? If you get what I'm saying, there are things and data points that could be gathered, and if things were done in a standardized, systematized, protocolized way, I'm looking at Don Lloyd Jones, one's ability to begin to compare and contrast and understand what might be the things that work or don't work, or common elements, that would be really pretty tremendous use of technology.
Yeah, if I could just put a cherry on top of that. So how many of y'all use the open evidence? It's like an AI-empowered, so the clinicians, if you haven't used that, I would encourage you to go look at it. The hard part used to be, as a family doctor, figuring out what I need to do for that person. Now, I take a really good history, do a good physical, put it in open evidence and says, here's what you need to do. I just saved a trip to the specialist. The hard part is having that person understand that, figuring out where their health literacy is around their life essential aid and what they would have to do, and then giving them somebody like this community health worker you're talking about to actually walk them through the process of doing it. And so it's interesting how AI is shifting from the diagnostics and getting the diagnosis and treatment protocol right, which is what you need a doctor for, to how do you actually get them to do that?
At the risk of everybody's leaning in, which I love to see. You put me in mind of a quick example. Actually, AHA-funded research from a strategically focused research network. We were engaging college freshmen because we wanted to actually do an intervention to improve their, what was then Life Simple 7, not their Life Essential 8 yet. And they were very resistant to actually receiving messages about improving their health. But when we really talked to them, and these were admittedly pre-professional Northwestern freshmen, what they wanted was an organizer. That's what they really wanted. Something that told them where they had to be when, what they needed to be doing, what they needed to check off their list. And then they were very receptive, if they had the organizer, to receiving the health information. So we created a win-win, we co-designed, if you will. Just a great object lesson that regardless of the community, they know what they want, they know what they need, and you're not going to get anywhere unless you actually address that. Finally, Dr. Shah, please ask your question.
Certainly.
We need the mic turned on for Dr. Shah, please.
It might be on now.
There you go.
Hi, can you hear me? Oh, yeah. Very good. Well, thank you all for this conversation. My name is Nilay Shah. I'm a faculty member at Northwestern in Chicago, and I like to think of myself as a community-engaged researcher, although I think the communities I work with have the final say on that. This is something I think is relevant to this conversation. I welcome your perspectives. I apologize if I express any half-formed thoughts because I'm not sure I even understand all of the nuances, which is we're talking about the role, in part, of digital technologies and how they might support health in an engaged way with communities. But what I struggle with is that the needs of people and communities are constantly changing and evolving. And so we may have some technological innovation that may allow us to better understand the needs of communities, and we may have a conversation with communities to understand what they need at that time. But how do we make sure that that process is evolving with the evolving needs of a community and continues to meet communities where they are maybe 6 months or a year or 3 years down the line? I'm not expecting any answers, but I would value your perspectives.
So I would just argue that we really need to think about digital determinants of health, just in many ways that we think about social determinants of health. We need to think of what are those factors around technology, around health digital literacy. What are those specific areas that are potential barriers or facilitators to utilizing technology, and how those evolve over time. So we can think of those at the individual level, things that are people understand about technology, but then there are more community factors, whether or not broadband is available, but even more more social and policy level factors related to access issues. And when we're designing interventions, when we're thinking about bringing in these technologies into interventions, these are questions that we need to be asking about repeatedly and iteratively through the process.
Yeah, what I would add to that is, when we're designing interventions, we must also always think about the social engineering of it, right? And the who's involved, and give folks, have bidirectional feedback, where we're not just taking an intervention and delivering it down into a community and then asking a question, but we have community folks at the table, and they're always involved, and that's how you continue to get the most up-to-date information about what's going on with that community, what's not working, how the needs have shifted. And I know we typically do that in some ways, but I think part of what I think SWI is thinking is we probably maybe need to value those voices and those inputs a bit more and integrate them into our systems and our interventions a bit more.
Thanks for that question. Did we address it satisfactorily? Great.
Yeah, so, but that's not, I don't feel like we've addressed your question really directly. And how do you assess a community? What is a community? How do you define that? How do you figure out what the tools are that are available? You know, I right now get to work in ecosystems called companies, corporations, and they have health insurance that often people can't use. They have point solutions like, oh, here's the diabetes, here's hypertension, here's musculoskeletal, here's emotional health, that they're getting 2 to 3% engagement in. And so when you really look at it, coming back to what you just said, if you sit down and talk to the employee and say, what do you need and how can we bring it to you? They could save a lot of money on silly solutions and actually do a lot of things that would make a huge difference. A quick example of that, we had a corporation, large eyeglass maker based in Dallas. They had a group of people in Los Angeles, like we're talking 1,500 people. They said, oh, don't bother with them because they don't spend any money. They don't cost us anything. Now, a lot of them are insured, but they don't cost us anything. So we looked in our data. Well, they're not getting physicals. They don't have a primary care clinician. They're not getting blood work done. So they were actually very high risk, and we went and looked at them. Every one of them had English as a second language. The majority of them were Spanish speakers first. The ones that had tried to use their insurance had gotten hit so hard financially, they didn't trust their insurance anymore. So they basically took their card, threw it away. And the way to work with that group was to go to the barrio, find the diabetes programs, find the free clinic for women who are pregnant, because there are many women who are pregnant that were not engaged in primary care or in prenatal care. And so we actually took that group, look at them, and they became a focal point of community-based interventions. And the irony is it didn't cost the company anymore because they still didn't use their insurance. They were using community resources where they felt comfortable in getting care. So that's just an ecosystem example of what you were asking is, how do you do that assessment for that community? And right now, primary care in communities, do they have access to primary care? Where is it? Is it community health clinics? Is it the jail? Is it private insurance? Is it corporate funded? And so we're going around the United States with Primary Care for All Americans, looking at every community and setting up groups of community members, not doctors, not, some of them are lawyers, and they will say, we want primary care for everybody in our community, and they will figure it out for their community. It's not like Big Brother is going to come tell you how to run your life. So whether it's a community as in geography, community as in corporation, that's what we've got to get much better at, I think. I think you bring up a very salient point.
And in the community of this panel, I'm going to discourage lawyer bashing and physical violence.
Thank you.
Just going to say.
Thank you so much. I appreciate that.
Sir.
Murray Harper with the Mississippi Business Group on Health. I too deal with employers, right? But everything I'm listening to here comes back to two things that I've seen from barriers to engagement. It's trust and privacy.
Yes.
Those are the two biggest things, no matter how well connected. And I'd love to hear from the panelists what you think on how to build trust and get past that privacy hurdle, because in the Southeast, a lot of men do not want to seek care because they're afraid of seeing what they get, and they don't want anybody to know their information. So anything?
Go ahead, please.
So for us, trust started with building out trusted partnerships with those who were trusted leaders in the communities we were working in, and really making sure that we brought them to the table, and that we formed partnerships with them. And then it really also started with, again, before, as a research physician, a physician scientist, before we started any type of data collection for a study or anything like that, we had to work with the community to get feedback. And so we had to make sure that that they trusted that the feedback that they were providing was actually being listened to, that it was being utilized as we move forward in designing interventions. But I think that trust element is so critical for not just research, it's critical for building out care systems. It is really foundational. I said, yeah, I really like that quote behind us where trust isn't a feature, it's a foundation. So.
And I'll just add that trust is everything. It's everything. And I would say you'll know you got there when most of the men or the women say, I'm in. And when you achieve that level of trust, they will be the ones who will convince the ones who say, I don't trust it. They'll be your trust agent. Yeah. So, and I think everyone here will agree. The one thing about trust is that it takes time. You don't know you're there until you're there, and there's no way to know how long it's going to take you until you actually get to that place. And it may be the most important investment to make in advance of trying to deploy and make use of technology. So agree completely with you.
You know, the other thing, Murray, that comes to mind when you say that is trust is the antidote for fear, and particularly with men. And a lot of employees and their family members, they don't go lean into how do I get healthier because they're afraid they're going to find out they've got something they can't afford to treat, or that it's going to take them out of the game. So they figure I'd rather just not know than to know and not be able to address it properly. I had a woman the other day that had stage 3 breast cancer that had known about her tumor for a year and a half, but she didn't choose to go to the doctor because her high deductible health plan, she couldn't get care. And if she did go and they diagnosed her and she got care, they wouldn't be able to pay their mortgage and pay for food. And so she had to make a choice. And so she chose not to get looked into knowing she had breast cancer. And that's the silliness that you talk about trust. But I think the other side of that is we've got to make sure that we give people the tools to be able to actually act if they find something terrible is going on, and then they will trust and lean into it. And the other thing I'll say is, you know, in a family doctor, in a specialist world, specialists want it to be around transactions because they can do their procedure, they can get their $3,000, they can go home. And they don't have to deal with all the hard part, which is the relationship. Yeah. But the truth is, trust is built through continuity and relationships. Right. And we've got to incent that and pay for that in America, and fee-for-service doesn't pay for either of those things.
Yeah, so I say with SWI, I mean, everything that we're doing, especially with Ashe, is all about trust. You know, Ashe has the community's trust already, right? So we were able to identify, you know, I didn't talk too much about how SWI landed with Ashe, but it was through this long sort of rating system where we picked all these different places in the city and we had the scorecard and so on and so forth. And Ashe scored like second to highest in ours, and then AHA came and said, look, this is the place where you need to be because the infrastructure is there and so on and so forth. And that's how we landed on it. So it's all data driven. What we do is all very thoughtful, evidence-based, data driven, research driven. But anyway, the point being, part of the reason why Ashe worked so well is because of the trust that had already garnered over 30 plus years in the community, right? The other thing is that SWI then had to prove to Ashe that we could be trusted. And a part of that was communicating our intent, and our main objective was to make an impact over and over and over again. It wasn't about publicity, it wasn't about making money, it wasn't about all these other things. It was really about the impact that we wanted to see made in the community. And so I think a big part, man, there's a lot of things going on. A big part of cultivating and sustaining trust is to make sure the person on the other side really believes what your purpose and your objective and your agenda is, right? And that it's really about helping them improve their life and improve their wellness and nothing else. And so I think that's been the challenge for SWI, but I think we're doing a really good job by always showing up, always focused on making impact and nothing else.
Thanks for persevering, Courtney.
Yep.
We have time for one more question.
Thank you very much for the engaging conversation. My name is Stelios. I used to be a clinician. I work in a digital medicine startup. I'm very interested in your perspectives of how digital medicine startups, as well as interventions that are blood-based, like Function Health, Supercharged, very recently prevention-related applications like the one by Verily called Me. I wonder how you think those factor into prevention and how those may differentially affect different communities that you may be working with.
All right, I'll jump in there real quickly. So with corporations, digital health came to us early and said, we want to be doing this, particularly around opiate use and other things that are huge problems that aren't addressed well. And we tried to implement them. There were two problems. One is how do they get paid for, and how do we get them engaged, and how do we do the accountability, because it felt like that should come from the doctor's office. It didn't feel like a corporation putting those things in place was appropriate, really, and it fell flat on its face and it failed. On the flip side, it's terribly needed. So the question is, how do you take something that is not being done in healthcare today, that can be translated into multiple different languages, can actually meet people where they are and move them along? How do you actually deploy it effectively? It's not through the doctor's office often. It feels inappropriate for employers. So I think it's sitting there right now, languishing or struggling at times, because we can't figure out how to get the right person with, kind of linked into that, and then give that person support as they go through that digital experience.
So unfortunately, I think that is the end of our time, but I want to thank our wonderful panelists for all their great insights, and thank all of you for attending today.